All right, everyone, settle in. Welcome back. So, last time we did a broad flyover of all the things that can go wrong with teeth. Today, we're drilling down. We're going right back to the very beginning, to square one. We're going to explore what happens when the whole process just doesn't start, when that initial blueprint, the dental lamina, fails to form. So, here's our roadmap for today. We're going to start at the lamina, obviously. Then we're going to dig into the clinical problem of missing teeth, what we call hypodontia. From there, we'll look at the genetics behind it, which is fascinating stuff. Then we'll get practical. How do we treat these patients? And just to make sure you've got the whole picture, we'll flip the coin and look at the opposite problem, too many teeth. And we'll wrap up with some real-world advice on planning for the future. Sound good? Let's jump in. Okay, so cast your minds back to our last lecture. We talked about issues with size, shape, mineralization, macrodontia, dents and vaginitis, all that good stuff. But those are all problems that happen during the development process. Today, we're talking about something far more fundamental. What happens when the ignition switch is never turned, when that dental lamina just fails to get the memo? And that failure of initiation, it leads us directly to probably the most common developmental anomaly you are going to see in your entire career, congenitally missing teeth. And I want to be super clear. This isn't about a tooth getting knocked out in a hockey game. This is about a tooth that was never, ever there to begin with. Getting your head around this is absolutely crucial for your clinical practice. So the official term we use is hypodontia, but you got to think of it as a spectrum. If a patient is missing just one or a few teeth, that's hypodontia. If they're missing 6 or more, and that's excluding wisdom teeth, we level up the terminology to oligodontia. And in really, really rare cases where there are no teeth at all, that's anodontia. For today, we'll mostly stick with hypodontia, but you need to know these distinctions for your notes and for communicating with specialists. Now, you can't just spot this by looking in the mouth. It's not enough. You have to see what's going on under the surface, which means you need a radiograph. And this panoramic X-ray says it all, doesn't it? This is a child with a known genetic condition, and you can just see these massive gaps where the permanent teeth should be developing. It's a stark, powerful image, and it's your #1 diagnostic tool here. And don't think for a second this is some obscure condition you'll read about in a textbook and never see. Look at these numbers. In baby teeth, yeah, it's pretty rare, but check out the permanent teeth. We're talking somewhere between 2 and 9% of the population. That means almost 1 in 10 of your patients could be missing a tooth congenitally. And you can see it shows up a little more often in females. The bottom line is, you will see this. A lot. Okay, so here's where we take a big step back and think like true clinicians. Hypodontia is very often more than just a dental problem. You need to see it as a potential red flag, an oral signpost that could be pointing to a much bigger, systemic, or genetic condition. So when you see a kid with multiple missing teeth, your brain can't just stop at the mouth. You've got to think bigger. And this is exactly what I'm talking about. Hypodontia is a key clinical feature in over 50 different syndromes. Ectodermal dysplasias are kind of the classic example you learn for your boards, but you also see it all the time in patients with clefts, with trisomy 21. The list goes on. Being able to spot this pattern and connect the dots, that's what's going to make you a fantastic diagnostician. And here it is. This is what it looks like when that patient is sitting in your chair. This is a young man with ectodermal dysplasia. Just look at the classic signs. The teeth that are present, they're small, they're conical, we call them peg-shaped, and you see these huge gaps, these diastemas between them. Also, critically, look at the gums. The bone, the alveolar ridge, it's thin and underdeveloped because there are no teeth to support. You need to burn this image into your brain. Okay, we've identified the problem, we understand the why. Now for the big question, what on earth do we do about it? Managing these cases, especially in a kid who's still growing, is a marathon, not a sprint. This requires serious long-term planning, and it is absolutely a team sport. You're going to be working with the pediatric dentist, the orthodontist, the prosthodontist, maybe even an oral surgeon. Everyone has to be on the same page. And sometimes the most straightforward solutions have the most profound impact. Just look at this before and after. On the left, you've got those classic conical teeth we just saw. And on the right, that's just some skillfully placed composite resin. We've literally reshaped his teeth. And I'm telling you, this isn't just about aesthetics. For a young kid, this is a life-changing confidence boost. It's huge. Now, for kids who are missing a lot more teeth, we have to bring in prosthetics. What we're looking at here is a young patient with a removable partial denture. This little appliance is an absolute workhorse. It's restoring the smile, for sure, but it's also restoring function for chewing and speaking, and it's helping maintain the proper height of their face as they grow. It's a really critical part of the treatment plan for these kids. So let's just do a quick recap of the tools in our toolbox. We've got composite buildups for reshaping. We have removable dentures. We can use orthodontics to either shuffle teeth around and close spaces, or to hold spaces open for something later. Down the road, we can think about more permanent things like crowns and bridges, and, of course, the gold standard, implants. But, and this is a big but, only after all growth has completely finished. Okay, time to flip the script. We've been talking non-stop about what happens when the dental lamina is underactive, when it doesn't make enough teeth. But what happens if it gets a little over-enthusiastic? Well, you get the opposite problem, supernumerary teeth, extra teeth. It's the same category of anomaly, a disorder of proliferation. It's just pushing the throttle in the other direction. This chart lays it out perfectly side by side. On the left, Hypodontia, a failure to develop, resulting in missing teeth. It's more common, and you usually see it with second premolars. On the right, supernumerary teeth, extra tooth buds, resulting in extra teeth. A little less common, and the classic location is right in the maxillary midline, what we call a mesiodens. They're just two sides of the same regulatory coin. All right, let's bring it all home. Before you leave today, I want to give you some practical, actionable advice that you can take with you right into the clinic. These are the kinds of pearls that will make a huge difference in how you manage these young patients and their families for years to come. Okay, listen up, because this is pure gold. These are the pro tips. First, timing is everything. Try to get them into their first appliance right around when they start school. It helps so much with social acceptance. Second, make their lives easier. Use fast-setting impression materials so they're not gagging in the chair. Third, for those really complex cases, think about an overdenture. It clicks onto the few teeth they have and is way more stable. Fourth, fluoride. Daily, non-negotiable. And finally, be smart with your scheduling. Use the long summer holidays to make a new appliance. It gives the kid plenty of time to adapt without the stress of school. So I want to leave you with this question to chew on. Our job here goes so far beyond just filling spaces in a smile. We're managing their growth, their function, their aesthetics, and maybe most importantly, their psychological well-being for years, sometimes decades. So I want you to really think about that. What is our true long-term responsibility to these kids and their families? We'll pick it up there next time. You guys did great today.